Very good evening to everyone, those who joined right now. And it's myself, Dr. Amos Mangoni, speaking for you. This is our second session. We finished one session just few days before. We hope that we can arrange another session also next session in future. We believe that you found our session useful and fruitful for you. The ECG is very common topic, not only for the exam. It is important for our day-to-day practice. We are trying our best to keep the ECG understanding discussion profile in a very, what I say, in the lower profile, not very advanced. So those who are preparing for the part 1 exam, especially for MRCGP, the question come from the ECG. Even the MRCP part 1 also, doctor can get help because they will need it in the future part 2. So in any licensing exam or for the degree diploma, the part 1 exam, the knowledge of ECG is very important. With the introduction, we are proceeding further. This is our institute to wish you here. And our topic, we decided to talk on the chamber enlargements, the atrial enlargement and the ventricular enlargement. And the main attention in the ECG will be to the P wave and the QRS complex. With the chamber enlargement, there will be related some other issues will come. And we will not take too much time. The process you already know that whenever you need, you will raise your hand and you can ask the question in between the talk. So don't feel shy to ask me, please. As much as possible, I will try my best to answer your question. And ECG will be ECG usually to be taught in interactive manner. It is not like reading newspaper or the book. For that, it needs time. So we divided our classes in the different slots, though we have to take more classes for that. Anyway, as I told before also, many ECG classes are available in the online or in live or the paid courses. And always I believe that we can give you some extraordinary ideation for understanding of the ECG. I hope that you will get it in our discussion ahead now. So if you start with the first thing to the P wave abnormalities to identify the atrial enlargement. I believe that you have gone through the basics of ECG, many other things, very available throughout. Even in our YouTube videos also, there are some basic discussion of the ECG. Many books you are having. So in the last class, I discussed some basics. So I don't think that to discuss again the basics. If you need, you can go through. We can provide you the links also. So our idea to see how to identify the atrial enlargement, there are, the two atrium, so left atrium and the right atrium. And the P wave is enough to identify these. You see that the main focus of the leads is long lead, not long lead, the limb lead 2 and the V1, that is the chest lead. So naturally, the appearance of the P wave normally different. In the lead 2, it is the the positive deflection you find. In the lead 1, that means the chest 1, this is the biphasic P wave. Remember, this is normal. That we discussed before. We have to remember the appearance of normal 12 leads ECG. So in the V1 is the biphasic. So this is the normal P wave. Now come to down in the right atrial enlargement. The appearance will be as such. It will be not that much high. The colored area is the changed appearance of the P wave. Is a diagrammatic understanding. It is very easy to understand. So there are two atria. So the blue color one, another is the red color. So overlapping each other, you can find that there is, and the notched P wave here. The upper, the wave, there is a notching. So it is the right atrial enlargement, and in the right atrial enlargement, usually in the V1 lead, this one is representing the right atrium, the blue color. It is written in the down. So the higher blue color means this is the right atrial enlargement. So we have to compare this thing in the red color and the blue color. You see, this is a normal size. If the size is blue color is or the green color rather to say, not the blue. So this green color is bigger than the red color, so it indicates the right atrial enlargement. ECG is not clear sometimes. So if we are confused to identify in the lead 2, so then we have to go to the chest lead 1. The come here that this notching is more important, more prominent here. In the left atrial enlargement, it is called as P mitral. You know, the mitral valve reside in the left heart of left side of the heart. So the name of the P wave is called P mitral. We will identify. And in the chest lead, you can find the red color. That means the negative portion of the wave is bigger than the positive portion. It indicates left atrial enlargement. So this is the very basic. Now we are going to the problem to you. That means for the discussion purpose, if it is given to you. Now time for interaction, please. Please, anyone raise your hand to identify which atrium is enlarged here or it is normal at all. So guess something, though the ECG, the squares are not mentioned. For general understanding by guessing, can you identify? So our attention to be the lead 2 and the chest lead V1. Try to identify any abnormality of the atrial size. Please look at and let us know. Then learning will be better, doctor. Can anyone say? Don't feel shy. You look at the lead 2. This is the P wave is here. Yeah, please, Dr.
Yes, I think lead 2 and 3, there is some large P wave.
This you mean the P wave and the lead V1?
Yes.
Any obvious? So what does it mean? This one high up means it is called P mitral. Sorry, P pulmonal. This appearance is called P pulmonal, abnormal P. So pulmonal means you understand the right heart. So it could be the right atrial enlargement. If we can identify the features in favor of the P pulmonal, it will be easy, but sometimes ECG may not be that much clear. So V1, the P wave is not much clear. Okay. Clear, Dr. Ibrahim? What is your telling?
Yes, in V1 it's not appear clear.
Yeah, so rather the lead 2 is clear.
Lead 2 and lead 3.
Maybe there
also.
many leads are there to show the feature. So what could it be now? The answer, just to compare with this, to compare with the previous picture, and everybody please have a look. So your answer will be this one, right atrium. Dr. Ibrahim, is the right atrial enlargement?
Yes, right atrial enlargement, yes.
Very good answer, doctor. Thanking you. And again, expecting that other doctor will join. If you don't talk, rather you will learn less. It is very true. In the ECG is a very live ECG recorded, and it is our collection also. Have a look, everyone. And there also enlargement of the atrium. Don't be busy with other findings because we are learning the ECG spotly, piecemeal. Don't be busy with everything. Just to identify which atrium is enlarged here. Please raise your hand spontaneously. Can you check? So you can check many leads, not that only the V1 and lead 2. You can find the features in other leads also. Suppose in the lead 1, you see there are some P wave changes. Lead 2 showing something. Lead, you see the V1.
V1 biphasic.
Biphasic. So the positive and the negative proportionately, which is bigger.
Negative deflection.
So again to compare this and give your answer now.
Left atrial enlargement.
Left
Left
atrial
atrial
enlargement.
enlargement.
So you
Yes.
mean the P mitral, you mean? P mitral.
Yes.
This is the P mitral, that one. There's a notching of the P wave. So if it is so this is the left atrial enlargement. Thank you, Dr. Ibrahim. Feel encouraged, doctor, to talk. Don't be silent. So it's very simple to know how to identify the enlargement of the P wave. Now the discussion will go that what is the reason of enlargement, is atrial fibrillation, there's some other thing, mitral stenosis. It will be the hidden areas. We are not here to talk about that, only to identify the ECG. So now come to another one to identify the left ventricular hypertrophy and the right ventricular hypertrophy. Very simple rules. There are many rules are there, but what we discovered, knowing this thing, left ventricular hypertrophy, there are two criteria. Sokolov criteria, Cornell criteria for the left ventricular hypertrophy. This one is the right ventricular hypertrophy. If you don't have the data, you can make a snapshot also. Okay. And I will give you now the question so that you can compare to identify which ventricular hypertrophies are there. So this one, you see the calculation as V1 or V2 plus R, V5 or V6 more than 35. And all the ECG you may not get it. So we have to follow the Cornell criteria. The SV3 plus R AVL. SV3 plus R AVL in the men and women. Their gender variation is there. It is for the left ventricular hypertrophy and the right ventricular hypertrophy here. So there may you see that TST, depression and other also, there may be ischemic insult. Many other features are available. So the topic is here just to identify that hypertrophy is there or not. The other diagnosis could be hypertrophy is there, means there may be, it is called the strain pattern also, left ventricular hypertrophy of the strain pattern. And this is the right ventricular hypertrophy. Usually the right oriented leads will have tall R, right? And in the last class, we tried to say some reciprocity also. Reciprocity means whenever the R wave is becoming shorter, S wave is becoming deeper. You see, if you compare also anywhere, you can find this. Wherever the R wave becoming taller, S wave becoming smaller, the reciprocity is there. For that, we are calculating the S wave and the R wave, depth of the S wave plus height of the R wave. This is the thing. So try to remember it. I think we can proceed now to give you the quiz. That means the question. In the ECG, try to identify the which ventricular hypertrophy is there. Don't think another issue many, just to identify the hypertrophy of the ventricle. Maybe there are some other issues also. Please raise your hand. Take few seconds. Try to compare and calculate this. As you make the snapshot, you can compare with this, doctor. Have a look, or I can give you the next slide also, but the screen, the picture size will be smaller. But apparently we can find something here. The left oriented lead is the V1 in the chest, right? And in the one in the limb lead. So you see that R is there. Usually R is positive, no doubt. Correspondingly, S wave is not visible here. S wave is not visible here. And if you find in the V5 and V6, you see R wave is taller, S wave is not much visible. And if you found in the right, sorry, V1 not in the left, sorry, I need to correct it. V1 is the right oriented lead. Sorry, just I correct my previous word. V1 is the right oriented lead, V5, V6 is the left oriented lead. So is the positivity more in favor of the V5, V6 or V1? This is one question. Again, if you think that one and other leads, limb leads, it is a left oriented lead, so R is up. To compare this, I'm showing you now with the same picture, the comparison mode. You can calculate and give your answer, please. Now look at this and look at this, the two picture with whom it is matching near about. To identify the left ventricular hypertrophy, it will be a Sokolov criteria. If Sokolov criteria is not met, then try to match the Cornell criteria. If the right ventricular hypertrophy is very easy, just the ratio of the R and S, right? In the V1, the right oriented, so R is bigger than S, definitely it is the right ventricular hypertrophy. It's very easy to understand. So Dr. Ibrahim, please, Dr. Ala Al-Rahman Ibrahim, please give your answer.
I think it's the left ventricular hypertrophy because
Left ventricular hypertrophy. Because which criteria it is fulfilling?
V1
B1 in
and
the
V6
B1
and
in the.
and
Do you
lead
think the
V1.
Sokolov, which one? Sokolov criteria or the Cornell criteria? Which one you are following here to match
I'm
it?
following 35 minutes.
35 minutes.
V1, yes,
So
V1
S is the
plus
V1.
V5.
Yeah, so it will be the near about 1 to 24. 24 is small square in the S, right? Or in the V1, V2, whatever, 24.
Yes.
And if you come to the V6, how many here? 1, 2, more than 10. And there is 3, 13. So 24 plus 13, definitely more than 35.
Yes. So left ventricular
Hypertrophy. Can it fill the Cornell criteria also, doctor, for learning? For learning. Cornell criteria. S in the V3, suppose we don't know the men or women, even then the maximum, if you can fulfill, so it will be men, women, both. Can it be more than 28? SV3, SV3, too much high, right? 1, 2, 3, 4, more than 4, near about 4.5. Tip is here. So 20, 15, 20, 23 around, right, Dr. Rahman? Please be with me. It will be easier for me, doctor.
Yes,
Don't be muted.
Right.
23.
Yes.
So the V3 23 and the R in AVL. So it involves the limb lead. R in AVL 23. So here around 8. Right? Around 8.
Yes.
8 and 23 is 31. 23 and 8 is 31. So it is more than 28. So for the men or for the women, it is also justified that ventricular hypertrophy is there. I think our colleague others, you understood. Very, very right. Left ventricular hypertrophy is very easy, doctor. It's very easy. Especially, it's very nice to understand the right ventricular hypertrophy just to reverse the ratio. Hypertrophy. The V1 in the V1, R will be bigger than the S. In the V6, S will be the bigger than R. That is the reciprocity, if you understand the word. Thank you. Now, look at this and what you are looking. There also maybe the criteria of the ventricular hypertrophy or not, or there is something different. Yeah, Dr. Ibrahim, we will say be connected. Let other doctor can see. Few seconds, it needs some time. So I'm giving the mic. You be connected, Dr. Ibrahim. Be connected, doctor. Yeah.
I think here right ventricular hypertrophy. Because
right ventricular hypertrophy. Right ventricular hypertrophy. So if you calculate, the R is bigger than S.
Yes, the depths.
R is bigger than S. Right ventricular hypertrophy. Yeah. There is some other thing also to be discussed. Anybody else to tell something? In the V1, R is bigger than S. You can say from here, R is bigger than S. Yes, especially in the V2. Again, if you think that in the limb lead also, the S is bigger than lead 1, not so. This is one thing. Another thing, that if we discuss about the voltage of the cardiac muscles, voltage, usually in the left ventricular hypertrophy or right ventricular hypertrophy, the voltage is higher. Voltage is higher means if you calculate the height of the R and the depth of the S, usually it will be more than 5 in the limb lead and more than 10 in the chest lead. Dr. Ibrahim, can you follow me?
Yes, right.
If it is not fulfilled, that more than 10 in the chest lead, more than 5 in the limb lead. So we cannot tell that there is hypertrophy. So rather, the things are different. Can you identify that any lead having the voltage more than 10 in the chest lead? That means the V1 up to V6 is there.
Yeah, yes, in V2 and V3.
V2, V3, is it more than 10? No, doctor. Can anyone help in our
5.
participant? Is there any more than 10? Do you agree?
No, no, no.
No,
Not more than 10.
not more than 10.
5.
Yeah,
6,
and in
7,
the
maybe 8.
and in the limb lead, doctor, is there any more than 5? Any more than 5?
Yes.
Where?
In
Which lead? Which lead?
AVL. AVL.
No,
More than 5.
doctor. No,
5,
doctor.
5. Exactly 5, maybe.
Exactly or less than 5.
Yes.
Please, why
1
not other
square less
colleague
than 5.
helping us, doctor? Better 3 people together to decide. No one. Be active, please, doctor. Be active. So it is also less than 5. This is also less than 10. So better to say something different. What could it be now? It is called peak to peak voltage. Peak means the negative deflection peak to the peak of the positive deflection in the ECG complex. So it is less than 10, it is less than 5. So what is the diagnosis now? ECG diagnosis? Dr. Ibrahim also, can you say? No one?
Low voltage right ventricular hypertrophy.
It is called low voltage ECG. Peak to peak QRS amplitude is less than 5 and less than 10. Try to remember, Dr. Pericardial effusion, any other surrounding the heart, electricity, the voltage transmission will be less. So pericardial effusion, COPD, lung covering the heart for the obesity, very common causes are there. So try to remember, doctor, this is called low voltage ECG. Low voltage ECG. Okay, Dr. Ala?
Yes, sir.
Thank you, doctor. Now the next one. Now coming something about the axis. What are the axis, Dr. Ala? Right axis deviation, left axis deviation, normal axis, and another one, extreme right axis. It is called northwestern territory, extreme right axis deviation. Dr. Ala, please be connected. So what we find if we evaluate, look at the heart, electrical axis is this manner. What I am following, the cursor in that way. So if electricity positivity is more in this area, it is called the left axis deviation. That means the left oriented. It is the normal. If you make a quadrant of the 360 degree, is the right. It is the northwestern territory. It is called the extreme right axis. So to identify this thing, we will focus on the lead 1 and the AVF. There are many other ways could be there, but simply 1 and AVL. Okay. Now, a description is here. If both 1 and AVF is positive, positive means the R wave is relatively longer than the S depth. We can tell it this is positive. So, in the both 1 and AVF is positive, it is normal axis. I will show you one normal ECG possible. So, then usually it is normal axis, positivity is there. But if the lead 1 positive, but AVF is negative. So 1 positive AVF is negative, it will be the normal or it could be something different. The left axis deviation could be there. To make it clear, we have to look at the lead 2. There is the lead 2. So lead 2 in balance, if there is left axis deviation, lead 2 will be negative. Remember it. But if the lead 2 positive, suppose we are discussing this thing, lead 1 positive, AVF negative, but lead 2 is positive, it will be the normal ECG. Lead 1 positive, AVF negative, as well as lead 2 negative, it indicates left axis deviation. Now come to the right axis deviation. Lead 1 is negative, AVF is positive. It will be the right axis deviation. Lead 1 is negative, AVF also negative. It will be the extreme right axis deviation. That means the northwestern territory. In each axis deviation, doctor, there is some underlying disease condition of the heart. So it is not the time to detail of that. Dr. Ibrahim, any query in your mind, please? From here. Any query?
No, very clear, sir. Nice.
So
Thank you.
now come to that ECG. Can anyone identify any axis deviation here? Just think, doctor, for a second. And you can unmute by yourself, doctor, anytime. The restriction is not here right now. Anytime you can unmute by yourself. Just look at the ECG and try to identify any axis deviation. Normal axis, left axis deviation, right axis deviation, or extreme right axis deviation. Anything here. Just to consider the V1, sorry, the lead 1 and AVF is very simple, doctor. 1 AVF. So both are positive. So both
All
are
of
positive.
them positive, so normal axis.
Normal, okay. Okay,
Lead
so we are,
1
yeah,
positive, AVF positive, lead 2 positive.
so what is the diagnosis regarding the axis deviation?
If all positive, so that normal
So
axis.
it is so normal axis, it is a normal ECG
Yes.
also. There are no other features at all, but we are focusing the normal axis. Very good, doctor. Thank you. Just to refresh our the understanding, both are positive, normal axis. Both are positive, normal axis. Thank you. Now here, look at and give your answer. Anyone, please. Already I have given the clue also here. Compare this. What could it be now? Which axis deviation, or normal or not? Dr. Ibrahim is ready. Anyone? We are expecting other doctor also. Sorry, Dr. Sharmin having the audio problem maybe. No more. So Dr. Ibrahim, please, your chance.
Lead 1 positive, lead 2 negative, lead 3 negative, AVF negative, so that left axis deviation.
Left axis deviation. That means electrical axis going to the left.
Yes.
Yeah. That means it is going to the left. 1 positive, AVF negative. Again, at that situation, we have to look at the lead 2 also, right? Because it may be the normal axis deviation also sometime with AVF negativity. So as a lead 2 also negative, so it is going towards the left side. So answer is, repeat please, Dr. Ibrahim, answer is?
Left axis deviation.
Left axis deviation. Very good, doctor. Very good.
Okay.
I think axis deviation is important. And the next one, another picture. Who can say the answer? Can check quickly. Very simple. So lead 3 is there also, and look at the AVF. So if very simply you have to compare the 1 and AVF and sometime 2. So AVF is up, it is down. Usually we fix the ECG by our thumb, left thumb, right thumb. If the right thumb is up, we can say that is the right axis deviation. There is another technique also when you fix the ECG by your hands. So it is up, it is down. So what could it be? AVF is positive, 1 is negative, could be right axis. Right,
Exactly,
doctor?
sir. Right axis deviation, yes.
It could be right axis deviation. In addition, you
Yes.
can look at, doctor, the lead to also towards the right up. It is also true, you see? It is strengthening the features. It is not down. 1 is down, but it is not down. It is up as usual. So it could be right axis deviation. Very good. Very good. Now here another ECG. Any axis deviation or anything you are getting? Please have a look. 1 and AVF. 1 and AVF. Doctor, what about the AVF? It is negative, right?
AVF negative. Yes,
Negative.
negative.
1 is
Lead
positive.
1 positive.
So it may be the normal also, right? It may be the normal also. But look at the 2. Look at the 2. Where it is. It is following the AVF or is it following the 1? What do you think? Following means AVF is negative, 2 is negative or not? This is the critical decision making.
Equivalent. Equivalent.
Equivalent. But usually what we expect in the lead to, normally it is not equal. Usually R will be the taller than the S, isn't it? Common issue.
Yes, in lead 2 normal, R wave is taller.
So we can say that R is less than the usual height, S is bigger than the usual depth. Logically.
So negative. So negative.
If it is so, what will be our decision now?
Negative, left axis deviation.
Left axis deviation.
Deviation. Yes.
Because this is up, this is down.
Down. Yes.
Left axis deviation. Good. Now another ECG for you. Just to tell you that this is extreme right axis deviation, that is northwestern. Only look at these. You see the S is very, very deep. 1. And the AVF here, it is also S. Both are negative. Do you agree? Both are negative. F also negative.
Yes.
1 also negative. Both are negative. So in context of the axis deviation, we can say that it is in the northwest territory. That means the extreme right axis deviation. Now another question actually here to show you what may be the reason of this extreme right axis deviation here. To identify this, we will learn something else. Look at the P wave. It is not usual. Please have a look. It is a down. S wave is down. It means that most of the leads are down. A little R wave could be there. So the voltage all are negative. Very uncommon, unusual. Right? Dr. Ala?
Right, yes. Yes, sir.
You mean that this is right axis deviation totally by the heart? That means heart turned to the right totally?
One might be dextrocardia.
Yes, possibility is there. But look at in the dextrocardia, if the right turn towards the right, heart turns toward the right, what will happen to the chest lead? 1, 2, up to 6.
Normally, LS in lead 1 until V3.
We can say simply, usually there is a progression of the R wave in the V1, normally. Progression of the R wave means the height of the R wave progressively becoming taller. So this is 1, this is 2, this is 3, here is 4. So it is following this, progressing. 4 or 5 will be the tallest, right? Maybe somewhere in the 5. It depends upon little positioning of the leads. So it is normally following. If it is the dextrocardia, what would happen, Dr. Ibrahim? The R here will be taller or as such in the lead V1?
R will be taller.
Taller.
Because
so it is not
normally
taller.
S.
It
Yes.
is a normal S or normal R is here.
Yes, normal.
So
Normal progression.
So now can we confidently say that this is dextrocardia?
No.
So other than dextrocardia, what could it be? Commonly it happen in the ECG recording. And usually the ECG person, not non-doctor, the nurse or other, there is an error in positioning the leads. What could it be? Wrong
Maybe
lead.
less. Yes. Less.
Wrong lead placement. Usually mistake happen in the right arm, the left arm. Right fixed with the left, left fixed with the right. It is found. It is found. But chest leads are okay. You see, chest leads are okay. So the highlighting point is here that the positive QRS in the AVR in addition, because you know that in the normal lead, AV are always down. So in the lead one, unexpectedly, all are down. In the AVR, most of the waves are positive up. So it is reversing each other. That means the right-sided voltage is more because we fix the left arm to the right for that, because heart is toward the left oriented. So left electricity is gathered by the right lead wrongly, for that AVR is high. And correspondingly, the 1 is negative. So it is a wrong lead placement. And the distinguishing feature between the wrong lead placement and the dextrocardia is R size, small r in the lead one. But in the dextrocardia, the R will be the taller. Clear, Dr. Rahman? I think you understood well.
Okay, very clear.
Of course,
Thank you
others
very much,
also.
sir.
Others also.
Okay.
Now come to these. What will be the diagnosis here now? The similar ECG. You see the P down as deep, AVR is high, tall. So seems to be wrong lead replacement. But is it wrong lead replacement or dextrocardia? So question is very specified. Please, anyone can say.
Dextrocardia, I think, doctor.
Yes. Yes. So the tall or a small r is important feature to differentiate the dextrocardia and the wrong lead replacement. Possibly some of you or all of you may have this experience in your life also. I have very important experience when I was working in the Gulf country with similar ECG. Anyway, I'm just giving you now to compare. You can make a snapshot, doctor. Upper one is the wrong lead placement and the lower one is the dextrocardia. Is very important, and academically also I can remember this ECG come in the MRCP part 2 written exam. Not very difficult, and I believe that you understood. Try to understand ECG in very simpler manner. So doctor, I think now we are going to finish. We are not taking too much time also. Finally, I am giving you one ECG and look at please. So many observations are there. Just asking you, chamber enlargement. Is there any chamber enlargement and which chamber is enlarged? This is your question. Don't give other answer. Only answer for the chamber enlargement, please. Think of. Feel free, doctor, to give the answer.
I think left ventricular hypertrophy, sir.
I am asking doctor, enlargement of the chamber, atrium, both atrium or the ventricle. Usually we discuss the left ventricular hypertrophy. We are not telling enlargement of the ventricle, yes. Right? So you are thinking what? Ventricular? Could be, doctor. Sometime ventricular if you measure the others. If I ask you any atrial enlargement is here. Suppose the P pulmonale or P mitral. Yeah, Dr. Liana, your answer, you are giving some additional answer also, right? But asking about the enlargement issue. I'm sorry that I cannot enlarge this feature, doctor. Try to understand the lead, the V1, any biphasic or in the change in the P wave, or lead 2. Look at the P wave you see here. This is the P wave. Can you say this is a P pulmonale or P mitral? In the long lead 2 also down, you can see. If it is as such, what will be the answer for atrial enlargement? This is the right or left? Not clear, Dr. Ala Ibrahim? Not clear to you? Anyone please can give the answer. It's very difficult. Is a P pulmonale or P mitral? Can anyone say? Nobody. Doctor, if you talk more, you will learn more. You talk more, you will learn more. Don't forget, please. Sorry, doctor. This appearance is P mitral. So the mitral valve is nearer of the left atrium. Yeah. So what could be the diagnosis? Look at. So the P wave abnormality, this is the P mitral and the left atrial enlargement. In addition, some of you possibly identified the left bundle branch block, and there is an premature ventricular complex also. This one, there is additional. So left bundle branch block is very good ECG also, and the premature ventricular complex. So we are not discussing this conduction problem here. You may see our YouTube video link also, arrhythmia and other maybe conduction problem we will discuss in the next class. So keep in touch with us, and I think we are at the end, and we like to thank you all of you to participate to this class. We will decide when we can go for the next, maybe within 2-3 days, we will arrange the next class, possibly of conduction issue. Around 1 hour, doctor. We will not take too much time from you. So I think it is our pleasure to thank you now. And I am requesting all of you that actually we don't have any separate group in the WhatsApp or anywhere. If anyone, you are in the group of the AKT or the MRCP, you can find the notification there, or different groups. So we're suggesting you to be in our WhatsApp group, especially AKT or MRCP part 1. You will get the update there. And the link will be the same for you, what we have given today, and you can share with others also. So thank you, doctor, for your kind participation. Thank you.
Thank you very much, doctor. Very
okay.
helpful.
Okay.
Thank you very much.
See you again.
You.
Maybe next 2-3 days after, preferably.
Okay.
I will let you know, everybody. Be alert, doctor. Be connected. Within these 3-4 days, we will arrange the next.
We hope that. Thank you, sir.
Okay, welcome, doctor.
Thank you.